Good morning, everybody. I think we'll go ahead and get started. I think everybody's had a chance to mingle and get breakfast and visit with some of our exhibitors. I'm Electra Paskett. I'm the Associate Director for Population Sciences in the Ohio State University Comprehensive Cancer Center. And I'd like to welcome you in behalf of the Director of our Cancer Center, Dr. Michael Caligieri, to the Ohio State University and to this conference today. So glad to see so many of you here, and we're really thrilled to be able to offer this conference today. I think you'll have a wonderful time. We have some fabulous speakers, internationally known, on the topic of lymphedema, and really experts in the field. So I'm really glad that you were all able to attend. I would like to start with some thanks and some announcements. So first of all, I would like to thank the Ohio State University Comprehensive Cancer Center and James Cancer Hospital for supporting this entire event. Appreciate their willingness to do that. And I would also like to acknowledge that we have the American Lymphedema Framework Project Steering Committee, as well as representatives from LANA, Lymphology Association of North America here. And at lunchtime, lunch is going to be kind of a working lunch. We'll be able to go out and get your lunch and come back in, and then you're going to be able to hear two updates from these organizations who are really trying to bring the issues related to lymphedema to the forefront in the world. And you'll be able to hear updates from them, and they'll explain a little bit about their mission, what they're doing in the future, etc. I want to also thank our staff. Jill is right out there, and she did the yeoman's job in getting this conference all together. And Marybeth Bagan from the Cancer Center, as well as Nancy Jones, and then Jill's staff, Ann and Jonathan, who are out there helping today. So if you will see our staff, if you would please thank them for putting this all together. They have regular day jobs, so this was in addition to their day jobs. I hope you also were able to spend some time, if not already, please do so during the day with our exhibitors, the OSU Stephanie Spielman Breast Center, including oncology rehabilitation. We do have lymphedema specialists here at the James. People were asking about that this morning, and we do have lymphedema specialists. We also have the Ohio State University James Diversity Enhancement Program exhibitors, Solaris and Juzo, as well as Mount Carmel Cancer Services. So if you would please visit our exhibitors, we appreciate them coming and contributing to this event also, and helping us make this a comprehensive event. Couple of housekeeping items. If you've not visited the restrooms already, they're just down the hall in between here and the registration desk on that back wall. In your packets, you will notice that there is an evaluation form. We would ask that you fill that out, and we will be collecting that at the end of the day. If you have to leave early, if you could please turn that in at the registration desk. We really do need the evaluations to give some feedback in terms of spending the funds to hold such a conference. In addition, at the end of the day, we will collect the name tags. We recycle the name tags, so we would appreciate if you could drop those off also, so we can recycle those. We are not able to offer CEUs for this conference. However, we do have certificates of completion. So those will be passed out at the end of the day. Again, if you need to leave early, you can stop at the registration table and pick up a certificate of completion. All right. I think that's all the announcements that I have, and I think we'll just start off the presentation. So I forgot to help our AV thank our AV helpers. Okay, so I'm going to start off and sort of give a little overview about lymphedema, what we know about the incidence, the prevalence, and what causes it, and talk a little bit about the research that we're doing. I want to just mention a couple of things before I start. First of all, we have a very diverse audience, and so I know that we have providers in the audience, we have researchers in the audience, but probably most importantly, we have patients, caregivers, and family members who actually have been afflicted with lymphedema. And so our presentations, we are going to try to also make sure that we explain a lot of the things that we're talking about. There will be time for you to ask some questions as well as to come talk to us one-on-one during the breaks. But I just would like to let you know also that I started down this path of researching lymphedema about 15 years ago when I was diagnosed with breast cancer for the first time and developed swelling in my hand. And back then, we didn't talk about lymphedema very much. Lymphedema really wasn't studied. And it was just something that, was expected or something that was kind of poo-pooed by some surgeons as, you have surgery, you're just going to have a little swelling. And that really made me angry. And so I decided to do something about it. And so for the past 15 years, I have been researching this subject, and I have been able to rub shoulders with some of the great people who you'll be able to hear from today. And I just want to let you know that with the work of these great people, as well as several other researchers, we've really moved forward. And lymphedema is now discussed. It's recognized as something. You have vendors who have products for you that are now designed actually to be a lot more comfortable, et cetera. And so we really moved a long way in the last 15 years, and I hope that we can move forward. So I'm going to start a little bit with just a basic definition. Lymphedema is a side effect of treatment, and it's due to the disruption of the lymph flow. There's a really nice diagram out here at the Slayer's table of the lymph system if you've not seen it, but again, to bring everybody up to speed, I kind of like to think of it as a highway through our body. And, if there's a traffic jam on the freeway, then all the traffic gets stopped. And that's how I like to think about the flow of the lymph fluid. It gets backed up. And it causes swelling and or pain in the affected area. And you can see here, this is just a cartoon of an example using arms or hands. As you'll see in my presentation today, the estimates of the incidence, prevalence, meaning the continued incidence of lymphedema, the duration of the swelling are varied. And you'll also hear some research on how lymphedema affects survivors' quality of life. The last point, which again you'll hear in the talk, is that really no prevention strategies have been proven effective to date. So these are sort of the key points, the take-home message from my presentation this morning. So who gets lymphedema? Well, mainly today we're going to be talking about cancer patients who receive surgery and or radiation therapy for their cancer. Other type of surgeries also can contribute to lymphedema, for example, CABG, coronary artery bypass graft, hip replacement. Lymphedema doesn't just only occur in the arms and the hands, it occurs in the lower limbs. It can occur in the head and neck, in the breast. If you have had a lumpectomy, for example, with radiation, it can occur in that breast, as well as the torso. For example, for reconstructive surgery, if you had tissue removed to construct a breast, lymphedema can occur there. I always like to use this example. When John McCain was running for the presidency, he's a melanoma survivor. He has lymphedema on this side. So a lot of the photographs would be taken of his other side, so you couldn't see the swelling. We really don't know totally why some people get it and others do not. There's research ongoing to try to figure out some factors. I'm going to talk a little bit about that. And there are some scientists, including Dr. Armour, who you'll hear from today, who is actually looking at genetic factors. Can we predict perhaps who will get it? And so what do we know about lymphedema? So as I mentioned, the accurate incidence and prevalence of lymphedema is complex. And really, there's very sparse publications in the literature about incidence and prevalence. And, you know, pretty much we could probably count maybe on both hands how many researchers are actually looking at this in the world. That's pretty scary to me. It is, about how few people are actually researching this. And really little has been published about primary trauma and iatrogenic-related lymphedema. We talked a little bit about lymphedema occurring in other places. So leg lymphedema is most often seen in survivors of uterine and prostate cancer, as well as melanoma and lymphoma survivors, because the nodes are removed in that part of that as part of the treatment. However, a majority of the published literature focuses on breast cancer-related arm lymphedema. And why is that? Well, we know that early detection and treatments have increased the number of survivors. And in 2012, today, there are over 13 million cancer survivors. That's wonderful, you know, that we're surviving. And so because so many of us are surviving because of these early detection and improvements in treatment, the focus is really now shifted again over the last 10 or 15 years to how we live our life as survivors. So really, how is our quality of life, and how, you know, what are the issues related to survivorship? So these are some of the issues really now that are gaining momentum in being studied in cancer survivors. Fatigue, nausea, pain, depression, anxiety, infertility, especially in our young survivors, sexual dysfunction, sleep disturbance, osteoporosis or weak bones, and of course lymphedema. And again, these issues are coming to the forefront in the last 10 to 15 years because we're curing more patients with cancer. And, you know, why is arm and hand lymphedema the one that's most studied? It's because if you look at the type of cancer survivors there are more breast cancer survivors than other types of cancers. So you see in the pink, 22% of the survivors are breast cancer survivors. You know, part of that helps because breast cancer is very commonly diagnosed among women, or is the most commonly diagnosed cancer among women. And again, the treatments and the early detection really help to keep us from dying. There has been some press, mostly recently in the last 5 years, about lymphedema. This is an article that was from the New York Times, and around the same time, the NCI Cancer Bulletin spotlighted lymphedema. But again, these are few and far between what you'll see in the press about lymphedema and what it is and the effects of lymphedema. So what do we know about the risk or the chance of developing lymphedema? And the abbreviation we're using, the LE, is abbreviation for lymphedema. You'll see in these slides. So we know that radiation chemotherapy increases the chance of developing lymphedema. Several studies have shown that. We've known for a long time that full axillary node dissection increases the risk for lymphedema. And our surgeon colleagues have tried to reduce lymphedema by doing a procedure called a sentinel node dissection, where they only sample the affected nodes rather than taking out all the nodes that they can see in the axilla. And it does reduce the risk of lymphedema. However, it doesn't erase it completely to zero. And also, we've had several studies that have shown that the higher number of nodes that are removed, as well as the higher number of those nodes that are positive, meaning they show signs of cancer, those also increase the risk for developing lymphedema. But I will tell you that we also have seen women who have maybe as few as 6 nodes removed who develop lymphedema, and women who have had as many as 40 nodes removed who don't develop lymphedema. So it doesn't mean just because you've had 40 nodes removed you will develop lymphedema. It's just a higher risk or a higher chance with the increasing number of nodes. So to continue this, we know that if women are overweight or obese at diagnosis, that increases their risk for developing lymphedema. From the research, there's little or conflicting evidence for age, older or younger, air travel, needle sticks in the affected arm, surgery on the dominant hand, meaning if you're right-handed and you had your surgery on the right hand, mastectomy versus lumpectomy, and hand use. There's little or conflicting evidence for this. However, I will tell you that, several years ago, and I wanting to say maybe 40 or 50 years ago, the American Cancer Society came out with the list of what you should do and what you shouldn't do, avoid needle sticks, avoid blood pressure, avoid, all these things. And those are just things that make good sense because they reduce your risk for developing an infection, which we'll see in just a minute also increases your risk. But here, we've actually seen very little documented evidence for those recommendations, even though those recommendations are probably the only thing that we have to consistently give to survivors now. We know that exercise and physical activity that are controlled, supervised, done appropriately do not increase lymphedema risk. And I really want to stress that done properly, controlled, supervised, under direction of a physician or a physical therapy do not increase lymphedema risk. And that bears further study. In terms of incidence, lymphedema can develop days or even years after treatment. I'm going to show you some of our data which shows that lymphedema really does develop within 3 years of treatment for the most part, but there is still a risk forever. And, I know stories of women who have been 20 plus years out who spontaneously develop lymphedema in the affected arm. So the risk never goes away. It never goes down to zero, but it does decrease. The overall incidence of arm lymphedema can range anywhere from 0% to 65%, depending on the diagnostic criteria and the method of assessment. And method of assessment is a key variable here, and I think our speakers will talk more about different methods of assessment. So what I want to talk about now is a study that we did in young breast cancer survivors. This was funded by the Army, Department of Defense. And what we did was we were putting together a cohort of young women. All these women were age 45 or younger when they were diagnosed with breast cancer. And the main aim of the study was to look at the resumption of menstrual function, the effect of pregnancy on breast cancer, and the effect of being treated for breast cancer on subsequent pregnancy outcomes. So those are the main outcomes of the study. Excuse me. The cohort is still ongoing. But I added in a kind of a secondary aim because this was after I was diagnosed with breast cancer, and so I wanted to, as I mentioned, do research in this area. So we added questions so that we could estimate the incidence and prevalence of self-reported swelling and explore the characteristics that were associated with developing lymphedema, as well as continuing to have lymphedema, and to assess the impact of lymphedema on quality of life. The women had to be 18 to 45 at diagnosis, stage 1 to 3 invasive breast cancer, diagnosed within the previous 8 months. Because we were looking at the effect of breast cancer treatment on pregnancy and resumption of menstrual cycles, they had to be having regular menstrual cycles at the time of diagnosis and no prior cancer diagnosis. Because we needed to get a lot of women in this age group, we couldn't do this at one center. We had to do it at multiple centers. And so we used mailed assessments, which is why we had to go with self-reported lymphedema questions. These folks did a baseline and an annual survey. They're still being surveyed. For quality of life, we looked at 2 well-validated measures. They're called the FACT-B, B for breast, and the SF-12. And we also assessed factors related to swelling, including personal factors, lifestyle, characteristics of the tumor, and characteristics of the treatment that they received. So for this analysis, we had enrolled 622 women. The mean age at diagnosis was about 38 years old. You can see the range in age from 20 to 45. The majority of the participants were white, living as married, college graduates, and employed full-time. Majority of the patients had an X-ray node dissection. You can see 83% had that. Most had chemotherapy and radiation. So this graph here shows you the incidence, okay, the development of lymphedema among these survivors from diagnosis, or our following at 0, through 36 months or 3 years. So you can see that the incidence increases over time. It's starting to plateau there at 3 years, but the steepest rise is in the first 18 months, and that is a little under 55%. This is ever reporting an incidence of swelling. So what factors were associated then with persistent swelling? So the graph I just showed you is ever swelling. And then we wanted to look at persistent swelling. And we had 32% of the women who reported persistent swelling. And those women, we say, these are really women who have some evidence of lymphedema. And what factors were associated? Well, first we have obesity. They were 2 times more likely to have persistent swelling. And again, increasing number of nodes. So a 3% increased risk for every node that was removed. So those two, again, are in line with what we saw. Now, the other thing we looked at, I told you, was the effect of lymphedema on quality of life. And I will mention this is the second study published that actually demonstrated a negative effect on quality of life among women with lymphedema. And you can just see that in all of these measures, the mental score, physical score, and the FACT-B, those women who reported swelling, this is self-reported swelling again, had lower scores indicating poorer quality of life. So that study followed women from diagnosis and when they developed lymphedema. We also decided to do a study in long-term breast cancer survivors, and these women were about 20 years out of their diagnosis. And this was done in the cooperative group, and the purpose of this analysis was to look at the characteristics of arm and hand swelling and the effects of swelling upon perceived physical function and mental health, again, quality of life. And this was one aim in, again, the larger cohort, where we wanted to see how these women 20 years after being diagnosed with breast cancer, how they were doing. These women participated in a cooperative group study, CLGB 8541, which compared 2 doses of a chemotherapy regimen there, Cytoxan, doxorubicin, and fluorouracil, and in 3 different 2 doses, a high dose, a low dose compared to the standard dose. And so our eligibility was they had to have been on this trial, and they must have been free from breast cancer for at least 12 months prior to registering in our study, no concurrent malignancy. So for this study, we had about 245 women, and the majority were 50 to 69 years of age, were white again, had incomes over $20,000, and had a high school diploma or greater. So we asked them if they had swelling, and 31% of these long-term survivors reported arm and hand swelling since their surgery. So the persistent swelling from the young cohort was 32%. Now we're getting 31%. That's pretty close. So, you know, we feel pretty good about somewhere around 30% is what we're going to see. Now, of these, 31%, so this is of the 31% who reported swelling, 76% reported current swelling. So the day they did the survey, they currently at that time had swelling. 49% of the 31%, half of them, said they had constant swelling. And the swelling was most often experienced in the upper arm. And of those who reported swelling since surgery, 88% said the swelling was mild or moderate, but swelling interfered with daily activities, the fit of the clothing, and perceptions of their general appearance. However, only 37%, again, of those who reported swelling since surgery, this is not 37% of the 245, this is 37% of those who had swelling, sought treatment for swelling. So there's a disconnect here. And almost half, 43%, also experience pain with the swelling. So this we feel is really an unmet need here that women have to get care for this. Regarding the relationship between the swelling characteristics and physical functioning and mental health, so how well can you walk, do your daily tasks, and how well are you emotionally? Swelling severity was negatively associated with physical functioning. So the more swelling, or if you reported swelling, you had worse physical functioning, which makes sense. However, in this study, these long-term survivors, swelling showed little association with mental health or emotional health, which we feel these are long-term survivors. They've been dealing with lymphedema for a long time. They're now coping emotionally, even though they're having problems with their physical functioning. So, I showed you a couple of prevalence estimates, but really the estimates vary greatly due to, first of all, the lack of standard diagnostic criteria when we do our research studies. Is it the percent of limb volume change? If you measure before your surgery and then after, it's that percent of limb volume change. Is it the absolute difference in measurements? How are you measuring? What's your method of assessment? Are you doing the arm circumference? Are you doing perimetry with the light? Are you, or bioimpedance or volumetric? How are you assessing the swelling? All those measures differ from one study to another. And there really is no universal mandate to do any measurement in a cancer care for patients. Some institutions, some physicians will do it on a regular basis, but there is no universal mandate. And we have reports from other studies. Excuse me. Dow et al. Reported that about 33% of breast cancer patients at least 1 year post-treatment had clinically significant lymphedema. So this is measured, not self-report, with 17% reporting severe lymphedema. Other studies, 75% of patients with head and neck cancer and had some form of lymphedema. 31% of patients undergoing surgical treatment for vulvar cancer were diagnosed with lymphedema 6 months post-surgery, and 34% of breast cancer survivors 6 years post-treatment showed clinical evidence of lymphedema at follow-up. And again, that's pretty close to 32, 31, 34. So we're starting to get some common, ballpark prevalence. However, in this study published by Hayes, 48% of the women reported arm swelling at least once since the baseline assessment. They did use the arm circumference and bioimpedance, and it also predicted mortality, which is now sort of where some of these studies are going to. Some of the big questions are, can we predict who will get it using, genetics perhaps? And now, what effect does the lymphedema have not only on the quality of life, but outcomes in terms of mortality from breast cancer? These are very interesting questions, that we need to start looking at. Our early work also found that women relied heavily on healthcare providers for information about treatment and side effects of treatment. And back then, when we first did this research, the women kept telling us, my provider did not tell me anything about lymphedema. Okay, now maybe they did, maybe they didn't, maybe they, it's such a stressful time when they're telling you, you have breast cancer, you have to have surgery, you either have to have your breast removed or you're going to have to come back for 6 weeks for radiation. Maybe they didn't remember that. But we kept hearing this consistently from the women when we did our study, that though they were not told. And I think we've now seen in several studies, and we've listed several studies here, that there is a negative effect of swelling on quality of life. So we can really say that that is well documented. So what we know about lymphedema prevention, can we prevent it? So we know now is the incidence, the prevalence, some of what causes it, excuse me, my cold, and the effects on quality of life, perhaps on mortality. So can we prevent lymphedema? So right now, the current prevention knowledge is really based more on clinical observation rather than any research studies. We know that exercise can improve the body's ability to respond to infection, trauma, injury, and inflammation. And Katie Schmitz published a study a couple of years ago that weight training, but supervised weight training, might prevent lymphedema or reduce swelling. However, we don't have any research demonstrating that. Physiotherapy, including manual lymph drainage, has been shown to reduce lymphedema incidence in some studies. However, we really need effective strategies to prevent lymphedema. So with that background, colleagues and myself, including Dr. Armour, took on a study. We're in the midst now of a randomized study across the United States to see if we can prevent or reduce the risk of developing lymphedema in women who are being treated for breast cancer. So we are implementing this program in a group randomized trial. The group meaning the unit of randomization is not the person, it's the institution that women are going to for care. And half of the clinics are randomized to the intervention group, half get education only. I'll talk a little bit more about what that is in a minute. And we're going to assess differences in quality of life, because we know from the other studies that quality of life is impacted by lymphedema. We're going to assess adherence to see if the women will do what we ask them to do in the intervention. And we're also going to assess the agreement between self-report of what women say is swelling versus actually measuring it. And the main goal, however, is to see if we can reduce the incidence or severity of arm swelling. So we're taking women who receive a sentinel node or axillary node dissection for breast cancer. And the women are followed for 18 months. We get physical as well as self-report assessments. And we currently have 34 sites around the United States who are participating in the study. This is sort of the schema. So we go to the institution, or an institution like Ohio State University is interested in participating. They complete a questionnaire which basically says that they see women with breast cancer, they have lymphedema specialists, and they have enough volume each year. And if they're approved, then we randomize them to either receive patient education for their patients, plus the tailored exercise intervention, or just the education alone. And then within each institution, a patient is interested in participating. They're registered before surgery, and I'll tell you what we do then. We get baseline measures. They then have their surgery, and then if they did receive their axillary node dissection, then they go on to step 2 registration, and the patient receives whatever the institution was randomized to, and the patients are followed for 18 months. This is our eligibility criteria again: stage 1 to 3 breast cancer, age 18 years and older, ability to participate in the exercise program, stay in the study area, have those nodal dissections. We are able to do arm measurements, as well as their arm can accommodate a standard side elastic compression garment. No prior history of breast cancer or lymphedema diagnosis, agree to participate. And if a patient is receiving neoadjuvant or chemo or radiation, provided they're eligible, we take the measurements before they receive their neoadjuvant therapy. And then the step 2 criteria is if they then go on and have the axillary node dissection. Those with a double mastectomy and having treatment on both arms are ineligible, because we do need an arm to compare to. So the outcomes, we'll be looking at lymphedema, both self-report and measurement. We're using Dr. Armour's 4-centimeter protocol. And then for health-related quality of life, we're looking at the FACT-B. Remember, we saw the FACT-B. The designers of the FACT added 4 additional questions to ask about arm swelling and arm use. We're looking at adherence, as I mentioned, and other factors that we think are related to the development of lymphedema, or the impact of developing lymphedema. Body image, fear of recurrence, self-efficacy, meaning do they have confidence that they can do the exercise that we're teaching them to do, knowledge of lymphedema, and of course, range of motion. So the intervention program we call LEAP, Jill, what do we call that? Lymphedema education and prevention? Okay. And so the education that everybody gets is the American Cancer Society guidelines for lymphedema preventive care, and basically what lymphedema is. Many women, again, don't know what it is, and so we spell that out. In the intervention program, they get a personal physical therapy assessment after their surgery. The physical therapist then gives them individualized exercise to regain range of motion or grip strength, etc. They then get taught about breathing exercises and also get a DVD that they're able to take home and see the breathing exercises. The purpose of the breathing exercise is to open up the lymph channels. They're given an elastic compression sleeve and gauntlet also, and told when to wear it. Not to wear it at all times, just to wear it at times when they would be using their arms. Now, we did a pilot study of this intervention, and we found that about half the women performed the arm exercises, and about 40% performed the lymph flow exercise. Only 35% wore the sleeve at 75%, at least 75% of the time. And the reason was they forgot, or time limitations. Those were the issues to adherence. But we do have some preliminary indication that we did see some reduction in arm volume when we did our pilot study. So the women come in pre-surgery. They do their baseline at 6 weeks post-surgery, and then 6 months post-baseline. 12 months and 18 months is when they need to come in. The 6 month can be done by phone. And these are the clinical variables we're getting from the chart to know what they were treated and things about their tumor. And then to try to improve adherence, because we know there were some problems with adherence. We ask them at each visit about adherence. We give them adherence tips. There's phone calls to remind them. They're given calendars so they can actually record if they've done things, and then we give them sort of incentives to remind them, like a refrigerator magnet, hand and body lotion, and a bookmark. They're also given a $10 gift card, and as I mentioned, the sleeves and gauntlets are provided by the study for the intervention women. You know, any woman who shows signs or symptoms of lymphedema immediately referred to a specialist for lymphedema treatment. So we began accrual in the study December 2006, and anybody who knows the cooperative groups knows that accrual usually goes slow. So we 460 patients registered to step 2, and as I mentioned, 34 sites, and we're hoping to close the study in early 2013. And the women are followed for 18 months, so it'll be a little while before we have some results, but we're getting close to the end, and we just need to push those other clinics to recruit the remaining women. So in conclusion, I hope that you have got the following points from my presentation. First of all, lymphedema really is an understudied condition. Second of all, it affects millions of cancer survivors. So, you know, 13 million, you know, we can do the math. 13 million, 22% breast cancer. If we estimate a third of those, that's a lot of women currently affected with lymphedema. And that's just breast cancer survivors. We haven't talked about the other types of cancers. And so, you know, we have some reports of the estimates of the incidence, prevalence, and effects. And all of these estimates and all we know so far suggests that we really need better preventive strategies. And so what you're going to hear today and some of the other speakers as well is really, where do we need to go with lymphedema? We really need to increase awareness and provide education in general, to the general community, to patients, to providers. We need to look at treatment. You know, do we have the capacity to treat? I showed you some data where, you know, only 37% of women who had swelling went to get treatment. We need more research, especially in prevention, ways to detect it, and ways to treat it. Dissemination then of effective strategies and policy issues. There's a lot going on in policy issues, and I think you'll get a flavor for some of that today, especially at lunchtime, when you hear about some of the work from the American Lymphedema Framework Project. So I have maybe 2 minutes for any comments or questions, but thank you again for coming. Thank you again for your attention. And I'd be happy to answer a couple of questions. Yes, sorry. Go ahead. I'm sorry, I couldn't hear all of your question. Are you able to come to, oh, Jill will give you a microphone. Thank you, Jill. Acoustics aren't that great in here.
What is the risk or likelihood of recurrence after you've had your lymphedema brought under control the first time?
Recurrence of lymphedema?
Yes.
That's a really good question, and I think it varies by person. I mentioned that the risk never goes away. So it's the same for once you've had your lymphedema resolved, the risk never goes away. You're always at risk for it to spike up again. And so that's why you have to be vigilant. So if your provider gave you, for example, a sleeve or a gauntlet or told you to do this or that, even though you don't have evidence of a lot of swelling, you need to keep following what they told you to do. But I'm glad that you got treatment and it resolved.
Well, it still hurts all the time.
Yes.
It's making progress. I
That's
reduced
good.
2 inches in my upper arm this past week after taking physical therapy and aquatic exercise.
That's good. So you need to follow what your provider said.
And
Thank you very much. Thank you. Yes. Jill will get you, I can't hear, I'm sorry. The acoustics in the room are not really good to be able to hear questions from the audience without the microphone.
Obesity increases your risk of lymphedema. So in your studies, do you control for that, or do you take that into consideration for a reduction in the swelling?
In our studies, we are measuring weight.
Okay.
We do measure weight. Our intervention does not deal with weight loss, but there are some other studies going on in the country that are looking at, does weight loss prevent or reduce lymphedema? That would be a natural thing to look at. But I will tell you, it's really hard to get people to exercise and change their diet to lose weight.
Thank you.
And if you've done it, congratulations, because that is superb. So last question, over here in the front. When here? We can take some break time. Do you all mind if we?
Hi.
Go ahead.
Oh, that's loud. Okay. I'm from Chicago, and I was very excited to come here and hear about this, which I heard about from my online support group for lymphedema. Not that we can fix blame to this sort of thing, it's our body, but when you talk about spreading awareness, my plastic surgeon is still in denial that lymphedema exists in the breast area, and his tram surgery, he feels, had absolutely nothing to do with it, or did not exacerbate it, and when I told him to take the expander out, I wanted no more part of the procedure. He was so angry with me, he literally made me cry in his office. So I do think that plastic surgeons need to be made aware of this situation.
Yeah, thank you for your comment. And we are really fortunate to have Dr. Cornier here. She is one of the believers and really one of the people who's working very, very hard to address this problem. But there are physicians out there who believe that, and I will tell you, when I was first diagnosed with lymphedema, I went to see my radiation oncologist. Said that's what you have, and I said, oh, okay. I went to see my surgeon, and I said, well, I've been diagnosed with lymphedema, and first it wasn't at Ohio State. I wasn't at Ohio State, and so you sit in the room. And you have the little towel. This is just the little towel you have on you. And he goes, put your arms out. So I put my arms out. A little swelling, but that's just from the surgery. So I never went back to him again. And, it's your choice to choose a provider who you feel comfortable with. And so that's one comment. The second comment is This is one of the goals of American Lymphedema Framework Project, is to get physicians to understand that this does occur, right? So you are right, it did happen, and you know, you need to be comfortable with a provider that understands the whole of you, okay? And then that can happen. Yes, sir.
My name is Pankaj Tiwari. I'm a reconstructive microsurgeon here at the James. I'm a plastic surgeon, and I think it's a very common problem in plastic surgery. We've done a lot of actually very innovative work here at the James. We did the first ever of its type vascularized lymph node transfer to a patient with extremity lymphedema after breast cancer only about a month ago in combination with Dr. Chang from Taiwan, who's probably one of the world leaders in this area. So we have a very kind of active program in this here, and I think it's something that plastic surgery is making a real active area of interest really right now. So there's a lot going on at the James, and our offices are here at the Stephanie Smuin Breast Cancer Center. Susan, our nurse, is back there as well. So if you have questions about some of the surgical treatments, which are very preliminary, I'd be happy to talk to anybody.
Right.
Thank you.
Thanks for mentioning that, and I know that Dr. Cornier might talk a little bit about that. Those treatments are really still experimental, and from the evidence that we have, insurers are not all paying for that treatment. So that's another issue where I mentioned policy. That's another issue where we really need some help to pay for treatments, not only things that are on the forefront, but I know from talking to people that there are women who cannot get their garments paid for. And the garments are not cheap, I know. So we've got a long way to go. Yes, and then you had a comment. Would you mind going over there? And while you're walking, I'll answer this question.
Are you aware of any studies that are looking at lymphedema incidence and prevalence in non-breast cancer patients?
There are, and Janice will talk about them. Okay, so hold on, good question.
I just wondered if your study was also looking at the women that were undergoing various forms of breast reconstruction.
We will capture all of that data from the women in our study. We will know what reconstruction they underwent. Yes, good question. Okay, any other comments, questions? Again, we have experts in the room. Raise your hand, my steering committee friends from American Lymphedema Framework Project. And so they're around if you want to chat with any of them, and you'll hear many of them speak today for questions. So we're now scheduled to take a break until 10:15. So help yourself to refreshments, visit our exhibitors, be back at 10:15 for Dr. Armour to start. Thank you.